See?
This is a nightmare.
Live. Good afternoon, everyone. Welcome to session 3, which is the clinical case presentations. If you hear crying babies in the background, it's not me here on Long Island. Natello is having some connection problems, so we've moved around a little bit as to who's going to be talking this afternoon. I'd like to introduce Dr. Vanessa Rouzier, who will be presenting our first case. Vanessa, the floor is yours.
Okay, welcome everybody to our afternoon sessions. We're hoping these clinical case presentations will be interactive. We're going to have some questioning for you, so we hope we look forward to your participation. As Sharon said, I'm Vanessa Rouzier. I'm based in Port-au-Prince, Haiti, and I'm also an assistant professor in pediatrics at the Weill Cornell Center for Global Health in New York. And this presentation is really courtesy of Andrew Handel from Stony Brook's Children's Hospital. Next slide. So this is April 2020, in the middle of the COVID pandemic, and a 21-year-old gentleman presents to a New York emergency room complaining of dyspnea and abdominal pain. His abdominal pain started about 2 weeks prior, and it's been increasing since, and it was associated with vomiting and diarrhea. The cough started about 5 days ago, and he feels like it's progressing, and he's a bit anxious and presenting with shortness of breath. So with just that information, abdominal pain and cough, shortness of breath in April 2020 in a 21-year-old, what's your differential diagnosis? And would it be different if we're looking at someone presenting in New York, Nigeria, or Thailand? Next slide. So we're going to ask the audience to vote. We have a few differentials for you. Next slide. So what's your differential for a 21-year-old gentleman with abdominal pain for the past 2 weeks and progressing, increasing, and shortness of breath in April 2020 in New York? A, acute COVID-19. B, lymphoma. 3, viral pneumonia. D, chemical pneumonitis. He's a construction worker. Or E, multisystem inflammatory syndrome, MIS-C, post-COVID-19. We want you guys to vote. We'll give you 30 seconds. Don't be shy. All right. Next slide. All right, we'll give you a bit more history. So he denied having any fever or sore throat, nasal congestion, no rhinorrhea, denies having a headache or a rash, no joint pains, no night sweats, and no weight loss. He's a construction worker, so he works in old houses that are filled with dust. But since this is New York in April, he's actually been quarantining for the past month because of the COVID outbreak. Recreationally, he smokes marijuana 2 to 3 times per day, no alcohol, and he lives with his female partner and their 2 young children. And notably, he emigrated from Ecuador 2 years prior. Next slide. On physical exam, his weight was 70 kilos, his blood pressure normal, 117/78. He was a little tachycardic at 113, but his SAT was normal in room air, 97%. His rest rate was 28. He was a bit anxious. His physical exam was notable for right-sided cervical adenopathy. So he had quite a few lymph nodes, and he had one that was a bit larger at 1.5 centimeters. His lungs, surprisingly, were clear. His abdomen was diffusely tender, but it was soft and there was no organomegaly. So in the ER, basic blood work was requested, and his CBC came back with 9,000 of white count with a predominance of neutrophils at 73%, 17% lymphocytes, 8% monos and 1% eosinophils. His hemoglobin was normal at 12, his hematocrit 39%, and platelets normal at 383,000. His ESR was elevated at 61, his CRP at 7.5, and procalcitonin was 0.08 nanograms per milliliter. Next slide. And the chest x-ray done in the emergency department comes back looking like that. So you scratch your head and you get a preliminary report that says ground glass opacities. So with this chest x-ray and the information we provided, next slide. What's your diagnosis now? Did we get the vote in from the first poll from the audience? We'd like you to vote again. Come on, next slide. So you have a 21-year-old man, abdo pain, short of breath, abnormal chest x-ray. What's your current diagnosis? Everybody, I'm just getting the poll, everybody said COVID. Not surprising, wonderful. This is April 2020, this is New York, this is the epicenter of the US. But now that I've presented you more information, would you change your diagnosis or do you remain? All right, let's vote again. COVID, lymphoma, viral pneumonia, chemical pneumonitis, or tuberculosis. Does anybody wanna, are we sticking with our diagnosis? 30 seconds. I love this, this was unanimous. Everybody said COVID. All right, next slide. Let's go to our panelists. Now, let's ask Andrew. This patient is presenting in New York City. This is in the middle of really a crazy situation with COVID. Patients are being admitted left, right, and center. Do you want to walk us through your top differential and what you thought?
Absolutely. So I'm Andrew Handel. I'm a pediatric infectious disease doctor out in Long Island in New York. So with this case, I think that the concern for COVID-19 is certainly relevant and appropriate. You know, again, this was April in New York when we were seeing the height of cases at that point. And so this patient's chest x-ray certainly goes along with it. Looked like there may have been a bit of lymphopenia as well. And so those things certainly make you think about it. But a few things were a little unusual for it. So his abdominal tenderness and the swelling in the neck was a little bit unusual. So when we take a step back and think about, again, he's a patient from Ecuador. We don't have much medical history. Is it possible that he has HIV and PCP? Tuberculosis is also a really good point, something interesting to think about. And I think that chemical pneumonitis, given his exposures, is interesting, but it sounds like he hasn't been out in those environments for quite some time, so maybe a little bit less likely. But I think starting with COVID and then going from there absolutely is a great place to start.
Great, thank you. What if this was Nigeria? Do you want to take us through what you would think, Nadia?
Sure. Hi, everyone. So I'm Nadia Sam-Agudu. I work for the University of Maryland, Baltimore, as a pediatric infectious diseases specialist. But I work full-time in Nigeria, and I've done so for the past 10 years. So for us, if he's presenting as a 21-year-old young Nigerian man to our clinic or emergency room, as it may be, the initial symptoms of having the abdominal pain for 2 weeks would with some vomiting and diarrhea would make you think, you know, is this sort of a slow onset acute appendicitis? Is it primary gastrointestinal? But then when you get the history of the cough, and definitely when you get the chest imaging, TB will jump out right at you. Now, COVID hit Nigeria in February, a bit later than it hits US and Northern America and Europe. However, as you may have heard, it really hasn't caused as much impact in our part of the world as it has in your side of the world. So really, COVID would not be a number one. COVID may come in as a thought process, but there are many more common things that could be serious presentations than that. So we would really consider TB. TB will definitely be there much quicker than I think it would be on the East Coast.
So geography makes a difference.
Absolutely, and definitely with that imaging, it's like it goes without saying, you know, that it's TB until we prove otherwise.
Thanyawee, do you want to make a comment if this was Thailand?
In Thailand, I work in Bangkok. So in April is the time that we have COVID transmission in Bangkok city. But I think from the chest X-ray, what I see is some of cavity, especially at upper lobe. So I think, and because of this is pediatric HIV, so TB co-infection should be coming up because of our conference. No, just joking, but I think with the sub-acute infection and also upper lobe infiltration in some of cavities, so that one tuberculosis should come up as first differential diagnosis.
Great. So thank you for our panelists. Obviously, very different perspective depending on where we are and knowing our epidemics. Absolutely. Let's go back to our slides. So I think the context makes a difference. And also, when you're narrowed, next slide, and you get sorry, that's not this one. There was another imaging slide. Do we want to go back? Ooh, back. Here we go. So I think what threw everybody off was the initial chest X-ray coming back with bilateral opacities in the context of COVID. I think we tend to be very influenced with what's going around us. But I think it's important to remember that medicine is complex and our patients bring with them their baggage and their complexities as well. So we went ahead and ordered a CT chest for our patient. And the findings, even though they still said ground glass opacities, there was a giveaway that was pretty significant that really changed our differential diagnosis. So the CT chest you can see here shows bilateral upper lobe consolidations, but typically what really gave it away was the cavitary lesions and the calcified granulomas and the significant mediastinal lymphadenopathy. And in the CT of the abdomen and the pelvis, there was the multiple mesenteric nodes as well. So next slide. So this was actually a case of TB, tuberculosis presenting in the time of COVID. But we were in denial. So the initial SARS-CoV-2 PCR came back negative. We still asked for another SARS-CoV PCR because there was people wanted to believe that it was COVID. But the CT with the cavitary lesions and the adenopathy really directs you towards tuberculosis. And indeed, his quantiferon TB Gold Plus was positive. His HIV workup came back negative, and his sputum smears were very positive. His AFB was positive. The PCR testing confirmed that this was Mycobacterium tuberculosis and that it was sensitive to rifampicin. And eventually the culture as well grew back positive. So next slide. So I think it's really important for us, we've seen, to have a broad differential diagnosis. But this is a pandemic and everything around us is changed. How do you manage TB in the time of COVID? And I think our panelists are going to walk us through some considerations. Nadia, do you want to start us off with management steps if this was Nigeria?
Sure. So in addition to thinking about management for the index patient, you also have to think about management for people in his household and his close contacts. And so while you're thinking of treatment, and thankfully it's a sensitive strain. So we do have access to GeneXpert, and we can do that on sputum CSF urine. And so we can put him on the RIPE drugs, rifampin, isoniazid, pyrazinamide, and ethionamide or ethambutol, and as a usual first-line treatment. Now, for other management, and I'm glad you used the word management, we'd have to now trace who is he in the home with, who was he exposed to, and who needs to be assessed for active TB. And if not active TB, those who are highly vulnerable should be on prophylactic treatment.
Yes. Andrew, do you want to talk to us about the challenges of handling active TB on a COVID completely overwhelmed hospital?
Absolutely. I think, so first, Nadia's point about thinking about family context is incredibly important. And again, this is a young guy who did have family members, but who lived in the same home. But in terms of the thinking about COVID, or TB in time of COVID, so the first thing, again, from a New York perspective, is just to keep it in mind. When this patient came in, no one was thinking about tuberculosis. And even though some of the data was staring at us in the face, it became incredibly important just to remember TB still exists. Some patients will have that. In terms of handling it in the hospital, fortunately, a lot of the isolation protocols are to some degree similar. Patients are, where there are N95 masks being used, they are put in isolation rooms when possible. And so fortunately, a lot of those things happen to hold over, even though this patient did not have COVID in the end.
Talk about the kids.
Okay, great. Let's go back to the slides. I think we want to really highlight some of those key points that we talked about.
And let me add something, please. Sorry. And I did mention I did mention about contact tracing for people at home, but we being pediatricians have to be, this is a quote unquote pediatric case who has children. So we have to be doubly concerned, particularly as pediatricians. So we know he has children, right? How old are these children? And the younger they are, the higher risk of developing a severe disease. We do have children here getting BCG at birth, but it wanes within the first 12 to 24 months of life. And so we'd have to make sure that those children are worked up for active TB. And if they have signs of active TB, which can be difficult to diagnose in children, we have to make sure that they are on full treatment. And if not, to put them over here, we would be putting them on isoniazid daily for 6 months.
Absolutely. This is the pediatric HIV workup. We don't want to forget the challenges of pediatric tuberculosis diagnosis. Thank you. Thanyawee, did you want to add anything before we go through?
I think the situation might be different. In Bangkok, we have lower case of COVID, but one of the obstacles is that people is very careful to come to hospitals because they're afraid that they will contract the COVID from the hospital. So in this case, I think if it's in Bangkok, we will have problems on follow-up and also to bring in kids to get evaluation, because we need to shift many services into telehealth or keep distance from the hospital. It might be a different situations from where you work in New York.
Yes. Very, very excellent points from our different panelists. Clearly, importance of keeping a broad differential and management considerations vary widely depending on our context. Let's go to the next slide. Next again. So the issues that needed to be considered were isolation protocols. This is New York, COVID versus TB, the immune workup. The challenges of treating pulmonary and extrapulmonary TB. Remember, he had significant adenopathy in on his abdominal CT. Contact tracing, we talked about, latent TB treatment, and prophylaxis of young children. Next slide. So just a few key points to highlight. So the patient was hospitalized on the general pediatric ward, and then with isolation precautions for COVID, but then he had to be switched to a negative pressure room once TB was diagnosed. So I think what we think initially in how we work up our patients clearly have impact when we're dealing with infectious diseases. He was started with standard TB treatment for drug-sensitive TB with 4 drugs and did really well, except that his cervical adenopathy grew. Initially, there was a period of watchful waiting, and then it fistulized, so he needed surgical excision. His immune workup was otherwise normal. Next slide. And as we talked about, contact tracing and treating for latent TB were really important. The twin girls were 2-year-olds, so they needed to be evaluated for active TB, as Nadia mentioned, which was negative, but they were treated with 12 weeks of once-weekly INH and rifapentine. And just mentioning briefly on the DOT challenges in the time of a pandemic. Our last slide, really our take-home points are, next slide. Oop, one too quick. Really, our take-home points was that we need to consider a broad differential diagnosis, even in the time of a pandemic. That our history and our physical exam are really key to leading us the right path to making the right diagnosis. And the challenges of being flexible in the time of a pandemic, but not to forget that our patients have their challenges and all their risk factors that need to be considered. I want to thank our panelists for this time and for Andrew for sharing this case with us.
Thank you.
Thank you.
So I think we're going to move on to our second case. Natella, I think you're on, so you get to moderate again. If you're not there yet, just to introduce the case, Elizabeth Whittaker will be presenting the case from the Imperial College of London. The commentators will be Nadia, myself, and Thanyawee. So go ahead for the next one.
So thank you for a wonderful case. Very good. Very briefly, given the challenging case, please go ahead.
Great. Thanks so much, Natella, for it's great to be here, and what a great TB case. I think in my clinic in the UK, where I do the TB service here, we've seen some really challenging cases of late presentations of TB as well in our young people. So all that coughs is definitely not COVID, and we need to be aware of that. I'm just waiting for my slides to appear. Lovely. So lovely, great. So I'm presenting a case of a young person who as well presented in April in London, where we also didn't we didn't have the most impressive COVID-19 suppression. Next slide, please. And so this is a 14-year-old who'd had a history of fever with dry cough and tummy pain and muscle ache at home. And they presented to A&E, which is what we call the emergency room in the UK, with a 4-day history of fever and rigors. She had generalized abdominal pain. There was some diarrhea with no blood or mucus, and there was no vomiting, but the patient was feeling sick with no urinary symptoms. And she was hot with a temperature of 39, and heart rate was very high. And obviously the bloods showed that there was an ongoing inflammatory process with a CRP of 150 and a raised white cell count with neutrophils of 12. Next slide, please. So this patient didn't really have any past medical history of note, was fully vaccinated, lived with her parents and 4 siblings. Mum had a cough a month ago. Interestingly, granddad had been unwell with a chest infection 6 weeks ago, but at that time getting a swab was like winning the lottery. So no idea whether he had COVID or not. And dad was a frontline worker in the police, but he had not had any symptoms, although we know that 50% of patients can be asymptomatic with COVID. She had a parrot. It's always fun in the ID history to get these facts right. Next slide, please. So we really looked for COVID, but partly because there was a possibility of going to the theatre, and an ultrasound of the abdomen was suggestive for appendicitis. So her appendix was removed, and the histology was suggestive of early appendicitis. And post-op, she seemed quite well, eating and drinking, and so was discharged home. Next slide, please. However, bounced back really quickly to the emergency room within 48 hours with fever and ongoing rigors. And actually, in retrospect, the temperature never really settled. Now had really severe abdominal pain, and also now really severe shoulder and neck pain, just not wanting to move at all, very uncomfortable. And the mum reported that when she was hot, her eyes were red, really tachycardic, tachypneic when they were hot, and the CRP had jumped up, maybe a post-op response, who knows. As well, the neutrophils had jumped to 15. Next slide, please. Examination was remarkable for tachycardia and tachypnea and a red throat with red eyes, holding the neck very still, but not Koenig's positive, and had a generalized abdominal tenderness, unsurprisingly, in particular around the appendicectomy scar. So the local team started on some broad spectrum antibiotics and fluids. Next slide, please. Again, in the next 24 hours, the blood picture continued to deteriorate with a rising CRP, a rising neutrophil count, and a falling lymphocyte count, with the platelets dropping to 58. Of note, a fibrinogen was over 7, and the D-dimers jumped to 5,000, and the albumin was falling to 27. The cardiac enzymes and the CK weren't remarkable. Next slide, please. So they rang us because we're the tertiary ID centre and wondering what was going on. We suggested perhaps actually this had never been an appendix and there was a retropharyngeal abscess given the way that the neck was being held so toxically, and she was quite toxic. Maybe there was a post-operative complication. Perhaps she was a scarlet fever and invasive group A strep, and made some suggestions about investigations, and we escalated her antibiotics to meropenem and metronidazole in case she had a resistant organism. We also queried whether there could be a clot. Next slide, please. So the next day, unfortunately, she acutely deteriorated, requiring fluid resuscitation. Her lactate jumped to 6 and was transferred on peripheral noradrenaline because they didn't have a central line to our intensive care unit. Next slide, please. So this is your poll question. So what do you think the differential is? Remembering it wasn't COVID in the last slide. So does this child have sepsis with an abdominal focus? Is this actually a toxic shock syndrome? Is it sepsis with another focus, perhaps a retropharyngeal abscess or an empyema or something else? Could they actually have had an underlying inflammatory condition or a malignancy that's triggered a macrophage activation syndrome? Is it actually just severe COVID-19? You know, we don't see it often in kids. Maybe this is what we're finally seeing. Did she have a myocarditis? So we'll give you a moment, and just to remind you that the polling button is just underneath the chat.
While we're polling, I wanted to make sure, can you hear me well?
Sorry, Nutella, I missed that.
Can you hear me?
I can hear you better, yeah.
Okay. While we're doing the polling, I want to pull on the
Oh, I'm afraid you are dropping a bit.
okay.
Do we have any polling results, or shall I go on to the next slide while we wait for those to
Please go on.
Great. Shall we stop here and let the panel have a thought while we wait for everyone to vote? We will judge you if you vote after the panel start talking, though. Go on. Okay. Do the panel want to chip in with their thoughts at this point?
Well, I think I'll go ahead. So if this patient is presenting in Nigeria as a 14-year-old with cough and high fever, non-localizing abdominal pain and myalgia, really given the fever and the myalgia, malaria will have to be on the differential. We don't tend to think of malaria as presenting with cough, abdominal pain, but it does. And so this is something that we would keep in mind with a patient presenting with the first presentation. Definitely the abdominal pain, even if non-localizing in a teenager, would still make us think also of appendicitis, as the team thought the first time. So we would probably have gone that route as well, while also thinking about malaria. I think I'll stop there for others to make some comments.
If this case is in Bangkok, I think it's post-operation and patient's quite sick. So I was thinking about sepsis.
Yeah. So here we are on Long Island. The story is the part that worries me the most, is that both parents had some respiratory illness before this child got sick. And unfortunately, while we were fighting the COVID wars, we got that story not infrequently. And as you heard from Liz, nobody was being tested. I want to say March and April, and certainly not a child out there was being tested for anything. Even when they finally got sick or into the hospital, they finally got tested. So certainly thinking about COVID or severe COVID would be one possibility, but is there anything else COVID related that we would have to think about? And the answer is perhaps.
Very good.
Yeah. I'll add that for the second, coming in with the second presentation, of course, and I would be thinking beyond, having malaria, and now go the sepsis route as well. In terms of COVID presentation, to be honest, we really don't have a lot of data on COVID presentation in children, much more severe COVID presentation. There's been one publication from South Africa with 23 children with severe COVID who actually did fairly well. Nobody died, and a lot of them had to be managed. I think one of the biggest issues they had were cardiac problems. But then in Nigeria, really, we are now compiling some of that information. If you think about it as Kawasaki-like presentation, even before COVID, Kawasaki is not something that's very common in this part of the world. In African countries, we do have scarlet fever and toxic shock syndrome, though. So that picture plus possible evolving sepsis is what we'd also be looking at with the second presentation. Thanks.
I should have said she's not pregnant or sexually active, because otherwise Karen Office would kill me. But anyway, just the first polling results show there that sepsis, other focus was 36%, and then severe COVID about another third, 27%, and then less commonly people worried about macrophage activation at 18%, with a sepsis and abdominal focus 9%, and toxic shock 9%. Very good. Well, we were quite worried about toxic shock. Should we go on to the next slide, please? Great. Oh, that's the TB one. But we should always remember TB. I don't think she had TB. Okay, great. So next one. So what tests do you want to do? You can have a think about it. I think we've done a huge amount of time, so I'm going to fly through this, and apologies for my rapid Irish chat. So basically, we did a lot of an infectious workup. We're really famous for that in infectious diseases. But most relevantly, she had abnormalities on her echocardiogram with really poor systolic function, and she had a dilated coronary artery aneurysm with abnormalities on her ECG, but we didn't find any evidence of any bugs. Next slide, please. This is her chest x-ray, which just shows some maybe minor changes on the left. Next slide, please. So our differential at that time, which was kind of early on, we hadn't really seen much of anything COVID in kids. We had our intensive care full of adults, was that this possibly was COVID, but we were quite worried about septic shock. And in retrospect, we should have been worried about multi-system inflammatory syndrome, perhaps. Next slide, please. So this is your next poll question. Given that all we've got are cardiac abnormalities, red eyes, and a persistent fever in a girl with neck pain and myalgia, what treatment would you like to give? And I think you can go on the presumption that this is multi-system inflammatory syndrome. And so the options are IVIG, steroids, biologic, and you can choose what you like. We've got no evidence for any of it. All of the above or none of the above. So we may be, just in the interest of time, shall I go on a little bit while people want to have a look at that, or do you want to give them another 10 seconds? Okay, let's go to the next slide. So what do you guys think?
So I take the hit on this one first. And yes, we have seen MISCs or multi-system inflammatory syndrome. And I appreciate from Nadia that it probably has a different name in each different country. And sometimes it's important for us to say, what is it we're talking about? And are those two illnesses actually the same illness? And as you can imagine, as you heard, the amount of data that we have that shows what works and what doesn't work is scant to none, closer to none. So in our institution, perhaps in many others, this child would have received IVIG. They would have definitely received a biologic, and most likely would have also received a steroid. They would have certainly been in the ICU. And all of the other inflammatory markers that you heard about, the D-dimer, fibrinogen, etc., as well as renal function, would have been something we would have very, very closely followed, because with our MISC cases, they get worse before they get better. Nadia, your turn.
Yes. So for me, as I said, outside of South Africa, we are now starting to really compile those kind of cases, partly because this hit us much later. And so when all these descriptions were coming out, it wasn't something that really was jumping out at us. But now we are starting to think about these things more often. Actually, last week I had a case that I thought, we should look at this, because this child had HIV but was presenting with these kind of symptoms. So in terms of treatment here, if someone were to come in like this and we thought this fits the criteria for MIS-C or PIMS as it may be, We would have, especially with the results of the recovery and solidarity trials of dexamethasone working and similarly glucocorticoids, we would be able to find decadron, dexamethasone, or other glucocorticoids to treat them. In terms of the biologics, whether or not there's good randomized data, the access to it is really not something we can discuss from in this part. We don't have access to that right now. And then in terms of IVIG, yes, you can get immune globulin, but you have to think about it in terms of who can afford getting this for treatment. But definitely the steroids. And so the results of those trials have been extremely welcomed in Nigeria and similar countries.
Great.
From my perspective in Bangkok, Thailand, most of the pediatric cases in countries is about a few hundreds, and we don't have any severe cases. But in terms of the experience that we learned from Kawasaki, which is quite common in Asia, whenever we have seen the coronary aneurysm, we would definitely give IVIG. But if it's related to COVID, I think if it's occurred in Bangkok, I would give IVIG plus steroid.
Great. So I think it's really interesting to think about the fact that it's not really seen in Asia, where that's all we learned everything about Kawasaki from. So it's such interesting pathogenesis of this condition. Next slide, please. Good. So, well, we gave IVIG because that's also our practice at the time, although we are doing a randomized control study now to try and work out whether IVIG is inferior or superior to steroids. And you can see just looking at these blood results, so the white cell count started to rise and the platelet count improved, but not before she also had steroids. So she continued to spike temperatures and went on to have steroids. So in the polling, just for everyone's information, 42% would give steroids, a third would give none of the above. Interesting, 17% IVIG and 8% all of the above. So you'll have to listen into my talk tomorrow. Next slide, please. And you can see here as well what happened to the D-dimer, that it went up for a bit and then responded with methylpred, and as well with the CRP. So you can see why she ended up getting a second treatment. So we normally give a 24-hour period after the first treatment to look at response, and then give a second treatment if they're continuing to deteriorate and not responding. Next slide, please. And this is just the final one, is the lymphocyte count finally picking up. All right, next slide, please. So this patient got better with IVIG and steroids. She didn't warrant a biologic because she recovered without it. Her neck started to move much freely. And it's a really interesting phenomenon that we've seen neck pain in these patients with no really known cause. We were able to wean her inotropes. She unfortunately developed proximal myopathy secondary to the steroids, and her 2-week echo still showed a dilated coronary artery. Next slide, please. She developed a clot, not uncommon in this cohort to get thrombosis, so we started putting them on prophylaxis, particularly if they're very unwell and non-mobile, and particularly if they have a high BMI. She had a normal MRI brain. She was vitamin D deficient, for what's it worth, but everyone's interested. Next slide, please. And there was a final poll question, and I'm going to actually just skip over this in the interest of time, because there is no right answer and we do all of those. So basically I can talk about that tomorrow. And so in the end, this was a gastro presentation progressing to shock with coronary artery dilatation of PIMD or MIS-C or whatever you want to call it, wherever you live, which had a good outcome. And her 6-week echo, and this has been our experience and very reassuringly, is that all of those cardiac complaints seem to settle down and improve. And I think that's a real take-home message. And she made a full recovery from her proximal myopathy. Although these children have developed huge amounts of anxiety, chronic fatigue and sleep disorders, in my experience, at the follow-up point at 6 months, we're seeing quite a lot of children who need psychological support. And I think my next slide is just my thank yous. Very good. Thank you for listening.